Sure, absolutely. Okay, can everyone see that okay?
Yes.
Excellent. All right, I'll turn it to you, Dr. Sangani.
So thank you, Mithra, and thank you everyone for joining the session. Today's topic I want to discuss is antifibrotic and progressive fibrotic interstitial lung disease. And as I introduce myself, I'm one of the provider at WVU Pulmonary Critical Care Sleep Medicine section, and also director for ILD clinic at our hospital. Next slide, please. I do not have any disclosures for this talk. My objectives for the talk today is introducing the basic aspects of interstitial lung disease or diffuse parenchymal lung disorder, starting with the definitions, some basic facts of epidemiology, mostly related to IPF, then classifications that I use usually, which is more clinically relevant. Little busy slide on pathogenesis, but just pointing out some salient features on that. We'll discuss what could be the management approach for in general for ILD, and then we'll look specific example for IPF and introduce the current therapeutics which is available as a disease modifying therapy. And then lastly, I want to discuss a few slides on a progressive pulmonary fibrosis or a PPF, which was recently proposed by ATS, and the emerging role of antifibrotics on that. Next slide, please. So as we know, the abnormalities of lung parenchyma, these terms have been used interchangeably, but I like the diffuse parenchymal lung disease terminology because it's not necessarily only the problem with pulmonary interstitium, but some of the tissues that adjoins the interstitium. Next slide, please. So there are two definitions from the American Thoracic Society and European Respiratory Societies to define DPLD. I like somehow the European Respiratory Society definition because it captures the essence of the disease process. So it is a non-infectious and non-malignant diseases of lung parenchyma that basically affects all three compartments. As I mentioned, it affects the capillary endothelium, the interstitium, and the alveolar epithelium, and eventually leads to either increased cellularity and or to increased amount of connective tissue disease, connective tissue deposition such as collagen and fibrosis in the terminal portion of the lung. That's why they call it diffuse parenchymal lung diseases. Next slide. So as we know now, there are about more than 200 clinical entities described. So it is very heterogeneous, very vast, but fortunately rare disease. And we have in the medicine, there are some disease has a history. The DPLD or IPF has some history behind it. We have known about this phenomenon or fibrotic lung disease over 100 years now. Next slide. So this current epidemiology, how is the distribution of different forms of ILD, what we see? Historically, we have always thought that IPF or idiopathic pulmonary fibrosis is the most common one, but they are kind of now our improved techniques for diagnostics, scans, and more systematic approach has led to this kind of classifications or the kind of distribution of the disease where IPF is 20%, chronic hypersensitive pneumonitis is remaining 20%, the CTD ILD 20%, sarcoidosis 20%, which is very specific granulomatous inflammation and occasionally leading to fibrosis. Pneumoconiosis counts about 10%, which we often see here more commonly because of our geographic location. And then some of the other idiopathic forms or even rarer form of interstitial lung diseases only falls about remaining 10%. So this is a busy slide. Essentially, what I wanted to point out on the top left of this figure, where there are several triggers which leads to specific reactions at the tissue level, starting with some risk factors environmentally acquired, which can be very common in given settings: tobacco smoking, air pollutions, occupational exposures, sometimes infections, microaspiration, gastric acid, some impact of the aging, some impact of the genetic predisposition, and some impact of autoimmune conditions. They all lead to injuries to the epithelial cell, alveolar epithelial cell injury, which leads to further complicated cascades of events where the immune system get activated. And then there may be if the immune system is activated with a helper T cell and a specific response directed to granulomatous inflammation, then patient may present as a granuloma, as you can see on the right-hand side, or what we commonly known as a sarcoid-like reactions, which can lead to ongoing chronic inflammation. Now, our body has amazing mechanisms of checks and balance. If the body is able to overcome this inflammation and induce the resolution, then there will be normal healing and normal lung tissue. But oftentimes, the chronic inflammation leads to another set of cascading events where it recruits the myofibroblast from the circulation, goes into further differentiations, and that's where the more connective tissue deposition starts happening into the lung parenchyma. So you can, in one way, you can see on the right inset picture of all the pathology. It's kind of a like a sequence of events. Either it could be granulomatous inflammation or the cellular non-specific interstitial pneumonia, which is just a chronic inflammation. Eventually, if the body is unable to overcome this initial stages of inflammation, it will lead to fibroblastic foci, and then more deposition of the fibrosis and the end stage fibrosis, which we know it as honeycombing. Next slide. So this is the classification that I often use when I see patients on a daily basis in the clinic, where it's been divided into two broad categories, whether you know the etiology or whether you don't know the etiology. Knowing the etiology is important because you can essentially avoid some of those exposures, or you can control some of the underlying conditions which leads to DPLD, and you can manage the patient same way. Whereas etiology unknown is a altogether different game, where a lot of different things you have to consider. It is, even though IPF is relatively common, IIP, but it's at times leads to a lot more differential diagnosis and confusion in the management. So quickly going over what are the 5 boxes that I rule out on etiology known. It could be some form of exposure related. Either it's inorganic dust in the form of coal dust, silica dust, asbestos dust. Some other jobs have a hard metal dust exposure that leads to ILD. Organic dust, such as some of the antigenic exposure happens from the birds, the hay, mold, atypical mycobacteria, or the smoking related particle exposure leads to very specific response on the lung, such as discriminative interstitial pneumonia, DIP, RB-ILD, which stands for respiratory bronchiolitis ILD, and LCH, which stands for Langerhans cell histiocytosis. The connective tissue disease, if the patient has underlying connective tissue disease, where their extra-articular manifestation happens on the lung, then some of this becomes an important player there. And one big evolving category always has been there is some form of drugs-induced ILD. The common example for that is amiodarone, methotrexate, nitrofurantoin, some form of chemotherapy such as bleomycin, and etc. The etiology unknown aspect of the ILD deals into some specific forms of ILD where it's a special treatment available for some of this disease, such as vasculitis-induced ILD, or the lymphangioma-leiomyomatosis, LAM disease, which is a female predominant ILD. As I mentioned earlier, if there is a granulomatous inflammation, it leads to more of a sarcoid-like reactions or sarcoidosis. And then the remaining all other etiology unknown is IIP, where the major distinction becomes between the IPF versus non-IPF. And the non-IPF could have also NSIP, which is non-specific interstitial pneumonia, cough, which is cryptogenic organizing pneumonia, LIP, which is lymphocytic interstitial pneumonia, and AIP, which is acute interstitial pneumonia. So if you get anything from this, this slide is DPLD or ILD is a very complex, very heterogeneous disease process where multiple form of ILD can be there. And it's our clinician's task to tease them out gradually. Next slide. There is a different way of classification. Sometimes we look at the patient, how acutely they present versus how chronically, means more than 6 weeks or sometimes more than 3 months of symptoms. And sometimes just names give out. If there is acute exacerbation of underlying ILD or acute HP or acute interstitial pneumonia or acute eosinophilic pneumonia, they're all going to present more acutely. whereas the remaining form of different form of ILD will present a more or less a subacute or chronic, and sometimes just insidious onset. Patient will not able to point out when everything started, but they just feel like they're progressively more symptomatic. Next. There is always a greater role of radiology in how you identify your interstitial lung disease. And the common theme on that is some diseases likes to go to the upper lobe or the upper lung zone, whereas some disease always identifies at the lower lung zones. And you can see the examples of each disease. So traditionally, all we know is the sarcoidosis, the silicosis, colorectal pneumoconiosis, HP, the Langerhans cell histiocytosis from smoking, berylliosis, and chronic eosinophilic pneumonia identify somewhat for upper or mid lung zones, whereas the lower lung zones are usually with UIP or IPF, NSIP, connective tissue disease ILD, asbestosis, and discomitative interstitial pneumonia. Next. So after knowing there is several ways of classifying the ILD and several ways of identifying them, what is the general algorithm how to proceed with the management of the ILD? So once you have clinical suspect of ILD, you go over the very systematic evaluation, starting from clinical assessment, some interpretation of the PFTs, the major role of high resolution CT scans or the radiology, some role of serologies, then maybe possibly offering them a bronchial lavage specimen and or biopsies depending on their suitability. That can also include the surgical lung biopsy, and then eventually leads to the the next stage is what we call multidisciplinary discussion, which could house the pulmonary doctors, the radiologists, the pathologists, sometimes the surgeons, and rheumatologists. And you come to some conclusion, whether there is a diagnosis of a given entity or you have a provisional or a working diagnosis, and you truly have unclassifiable ILD. And then based on your provisional diagnosis or actual diagnosis, you offer them appropriate treatment, and then you monitor the disease progression, which could be either through clinical assessment, the PFTs, and the follow-up scans. And then you define whether disease has progressed, and you kind of quantify the disease behavior and then call it progressive pulmonary fibrosis. So that's where, so this has become in last 5 to 7 years in ILD world, progressive pulmonary fibrosis, whatever your underlying etiology of ILD, but progressive pulmonary fibrosis happening in the ILD has found some wider recognition. And there's a lot more focus on monitoring the disease progression and then define them in which category they belong. Next. I think I already mentioned that, yes. So similar algorithmic approach has been adopted in many different ILD conditions. For example, let's look at the IPF. What is the current based on the very recent, just this May, the guideline that came out for IPF, what is the diagnostic approach? As we mentioned that once you see the patient with suspected having IPF, IPF is a diagnosis of exclusion. So you go over the extensively their history, rule out other associated conditions or causes. If you don't find anything, then you offer them as HRCT and try to look for the very specific pattern called usual interstitial pneumonia or probable usual interstitial pneumonia. And then differentiating that is with indeterminate for UIP or alternate diagnosis. Offer them multidisciplinary discussion, MDD. Offer them if they have an indeterminate pattern or alternate diagnosis. Occasionally, you have to offer them additional diagnostic, such as bronchial oral lavage with bronchoscopy, transbronchial lung cryobiopsy, depending on which institute they go. And very rarely, not always, but this surgical lung biopsy, and then come to conclusion whether it's a truly IPF versus alternate diagnosis. Next line, please. There may be some animation here. Yes. So what is the current therapeutic approach? Once you conclude that patient has a UIP or probable UIP and almost the clinical syndrome of IPF diagnosed, then what is the current therapeutic approach? What does the evidence tell us? So there have been, the IPF has always had a greater interest to explore a lot of therapeutics, and there have been multiple number of trials been done. in the last couple of decades, where they have employed various form of therapies. And based on some of the therapies, what was a historic practice, it has been completely abandoned now. The one example is that we initially thought IPF is some form of alveolar epithelial injury and chronic inflammation. And how do you treat the inflammation? With immunosuppression. So those patients were given a trial of a lot of corticosteroids, azathioprine, and some other form of aggressive immunosuppressive therapy. And the landmark trial, that trial name was Panther trial, which came out in 2012-13. We learned that those patients died more if you offer them more and more immunosuppression. So that has completely become obsolete for the treatment of IPF. So you can see that this one of these articles I reviewed provides a list of different therapies, and then which one was the potentially harmful therapies, which one was potentially ineffective therapies, and then evolving into what is now kind of a standard of care is effective or the disease-modifying therapy, which centers over the two antifibrotic drugs we have. One is called nintedanib, the other one is called pirfenidone. Nintedanib is branded as Ofev, and pirfenidone is branded as Esprite. Next. So what is the current mechanism? So I will quickly just focus on now antifibrotic, coming to our the topic of discussion, what is the current mechanism of action? So we reviewed the overall pathogenesis of ILD on the earlier slide. And if you look at that lower part of that slide and then focus on where the fibrosis derives. So as I mentioned, the fibroblast gets recruited into the pulmonary parenchyma. Either the source could be internally through the lung parenchyma or through the blood circulation. And there is a lot of evolving research and kind of interest in that as well. But what happens is a downstream cascades of events where there is a multiple role of growth factor and the related receptors, and TNF alpha and the TGF beta. So those two are predominantly inhibited by the pirfenidone, whereas the growth factor related mechanism is predominantly inhibited by nintedanib. And the end result is that it prevents the differentiation of fibroblast to myofibroblast, which is usually the cell that deposits the collagen in the lung parenchyma. And that's what the end result is, that there is some stop or kind of some pause to this mechanism to allow less fibrosis in the lung. Next, please. Thank you. So the what is the current knowledge what we have? As I mentioned, nintedanib mechanism of action is some form of a tyrosine kinase inhibition, leads to inhibition of several growth factor receptors. It was explored in Impulses 1 and 2 trial. The inclusion criteria was anyone with restricted lung disease with FVC, restricted FVC, and the diffusion capacity between 30 to 79%, and the diagnosis of IPF. What was the main finding? It slowed the decline of FVC. So compared to the placebo, the guys who received the IPF, the patient who receives the nintedanib, they had at a 1 year time frame, they had almost 50% less decline in FVC. So they both decline. So that's kind of a little interesting how you tease out the details, but how it has been characterized that that's the relative gain of a lung function. And then there was additional signature that came out on Impulses 2 trial that it reduced the time to first exacerbation, which is very deadly event for IPF folks. On the flip side, pirfenidone was also explored extensively. In IPF, it has a combined antifibrotic, antioxidant, anti-inflammatory effects. There were 4 randomized control trials has explored pirfenidone, capacity 1, 2. There was 1 Japanese trial and the Ascent trial. And the effect was almost identical. It slowed the decline of FVC in the IPF patient who received the drug by almost 50%. And a very interesting signature came out that there was some mortality benefit was identified when they put all these patients in a pre-pooled analysis, all these patients from the 4 trials. Next. This is what I mentioned earlier, that there is a gain of about 50% of FVC compared to the placebo. So if you can, the red line is a placebo guys, which continues to decline over a year time, whereas the blue line is the patients who will offer this one of this treatment. Thank you. Next. So this is a very interesting, emerging data, and this is a good article to refer to this, that where we live, has not been any therapy which has shown the impact on the survival of IPF patient until some early signatures started coming out from the antifibrotic therapy. And you can see the survival rate is better, and the hazard ratio is 0.63 with a significant value. And this was, I believe, our one of the European registry, Insight registry of IPF patient, which has about 600 or 800 patients, and they followed their behavior. And then just vital statistics over 2 years who was placed on the antifibrotic therapy. And you can see the curves is already started separating. So this is a remarkable achievement if this continues to be proven, because traditionally what we have learned from IPF is the progressively fatal conditions, and the time to so the mortality the calculation is about 2.5 to 3 years from the diagnosis. So that's that we call as a median time from survival from the diagnosis. So if this trend continues and a lot more patients offered antifibrotic therapy, then that statistics will be challenged pretty soon. Next. So I want to introduce this concept after reviewing some details on IPF management and antifibrotic, and then what is current understanding of what we call progressive fibrosing ILD. So the IPF tend to progress a lot, but so does some of the other different form of ILD, which has some overlapping features at times. Sometimes it's difficult to identify them, but one behavior that consistently comes out that some form of fibrosis always progress. If the patient is one of those unfortunate one. So let's review that some in next few slides. So based on that understanding, there has been a lot of literature, if you look at last 5 to 7 years in PubMed, about evolving concepts of progressive pulmonary fibrosis or progressive fibrosing ILD. And then in the end, ATS took a stand on this with different other societies based on the guideline just came out this year in the May. They said, all right, let's just define the progressive pulmonary fibrosis. And that was based on these 3 domains. So if any patient with ILD of a known or unknown etiology other than IPF, who has a radiographic evidence of pulmonary fibrosis, and the PPF can be defined by having at least 2 out of 3 criteria within past 1 year with no alternate explanation. So I'm really glad they include these worsening respiratory symptoms as well, because oftentimes patient themselves feels more symptoms, but we rely heavily on the PFT criteria or the radiographic criteria. But then now this is considered as one of the criteria. Then they define the progression based on the PFT on the 2 parameters, and either one could be there. Absolute decline in FVC 5% or more predicted within the 1 year of follow-up. The similarly decline in DLCO, which is corrected for hemoglobin 10% or more within 1 year of follow-up. And then how did they define the radiographic progression? You should have 1 or more of the following. And those criteria are extensive, but people who do this on a daily basis, they probably will identify with some of this criteria. What are those? The increased extent or severity of traction bronchiectasis or bronchiectasis, the emergence of a new ground glass opacities with traction bronchiectasis, more reticular changes came out in the scan, increased extent or increased coarseness of the reticular abnormality, start seeing a lot more honeycombing, or there is an overall increased lobar volume loss. So all this can consider as one of the criteria for that defines the radiographic progression. Next, please. So what is the current distribution of this progressive pulmonary fibrosis or progressive fibrosing ILD in a very different forms of ILD? So this is relatively the same classification system that we saw earlier, but the shaded area is what is our current knowledge, how many proportions of those patients progress. So you can see there is a good number of progressions happens if you start from the left to right. The most of the IIPs, which is idiopathic interstitial pneumonias, excluding IPF, have a progressive component into that. and some of the autoimmune, such as rheumatoid arthritis or systemic sclerosis or mixed connective tissue disease, almost all of them sees the progression of fibrosis over the years. The exposure-related HP is notoriously just very much similar, behaves like IPF, but almost half of them progress. Very interestingly, the occupational lung disorders, such as coal mining or the pneumoconiosis, almost 40% of them progress based on this data. And this just the similar thought for the other form of rare form of ILDs, but not as much progression as we discussed for the earlier forms of ILD. Next, please. So I think you may want to, yeah, there may be 3 animations on this slide. So once they they may have come out with a definition now, but how they build up on this, that once these drugs, either nintedanib or pirfenidone, were explored for IPF, they started exploring already in the clinical trials whether that will have impact on the other forms of ILD, which is progressive. So non-IPF ILD, which can progress. And one of the landmark trial which led to its approval, the nintedanib's approval for progressive pulmonary fibrosis for non-IPF conditions by FDA, was based on this trial called INBUILD trial. And you can see the distribution of their patient population. So they have almost 25% of them were hypersensitive pneumonitis. The next quarter was autoimmune interstitial lung disease. Then they have included other form of idiopathic, non-specific or ILDs. Then there is a good chunk of patients which you just cannot classify them based on the patterns. And then some rare form of ILD they also explored. They also included some patients with occupational exposure-related ILD, but they did not specify whether those patients have PMF lesions or the other form of black lung disease-related processes. Next. And what is the impact? So they looked at if you look at any trial of looking at the antifibrotic, the endpoint is change in FVC, and they look at how much was the change. So patients who were offered the nintedanib and the patient who were offered the placebo, there was a separation of the curve, and there was some gain of the lung function based on there is a less decline in FVC. So similar signatures as we saw with IPF patients. Next. And this is looking at the concrete number into that, like how much ml of IVC, ml of or milliliter of FVC was gained for each group. And if the patient has, I want to just make a quick point, is if the patient has underlying UIP-like pattern as a fibrosis on the scan, the gain is even higher. Next. And then there were some other form of, this is a very recent publication based on the INBUILD, but they did the subgroup analysis on very specific to the underlying conditions. And you can see that overall, the forest plot was favoring the nintedanib use with gain about 100 ml of FVC over a 1-year use. Next. Keep hitting next. This is, I just am listing all the trials which has been either employed already or under the current enrollment process, looking at the PPF process and exploring the use of different form of antifibrotic. Essentially only 2 form of antifibrotics we have. INBUILD trial we already explored and looked at. Pirfenidone has been looked with 3 or 4 different trials. Unfortunately, 1 or 2 have been stopped early because of the slow recruitment. However, their end conclusion was that when they did some statistical matching and analysis, that there was a similar signature like nintedanib. However, I should make a point that pirfenidone yet not approved by FDA for this reason. Next, please. So what are the guideline which explored the definitions of PPF? They also made some recommendations what to do with the antifibrotic in certain situation. So as I mentioned, pirfenidone has been explored, but no conclusive trial results has been reported. So they say that we recommend further research in efficacy, effectiveness, and safety of pirfenidone in both non-IPF ILD manifesting as a PPF in general, and then specific form of non-IPF ILD manifesting as a PPF. And then for the nintedanib, they actually suggest that therapy with nintedanib in patients with PPF who have failed the standard management of fibrotic ILD other than IPF. Now, it is a conditional recommendation, low quality evidence, but that all I believe is going to improve as next iteration of the guidelines come out. And again, they very specifically or categorically mentioned that further research is required while looking into the specific types of non-IPF ILD manifesting as a PPF, and then explore nintedanib into that process. Next, please. Again, a busy slide, but it is extension of some of the previous algorithm we saw. So here it's on the top row, it's look at the different ILDs and what is the current standard of treatment in the successive rows. Hit one more time. And what I want to point out is that after you give them a standard therapy or standard of care therapy, consider antifibrotic nintedanib particularly, and nintedanib or pirfenidone for IPF. And because if you define those patients as a progressive pulmonary fibrosis, there is a good role of using antifibrotic if the patient can tolerate the therapy. Next, please. So this is probably my last slide with the conclusion. So as we know, it is the heterogeneous disease process with complex classification systems. It requires a very tedious task from the pulmonary. Usually pulmonary guys happen to see this patient, and we do a good job at our ILD clinic on that. Greater recognitions of a pattern, and then systemic evaluation sometimes leads to diagnosis. And then as I introduced the subject of progressive pulmonary fibrosis and the role of antifibrotic, particularly nintedanib, and in future I anticipate pirfenidone in the same category as well.
Thank you so much, Dr. Sanghani. You did such a wonderful job explaining such a complex condition. So thank you. We really appreciate that.
I would, if we have time, I would be happy to take questions.
Absolutely. Yes, that would be great. So if anyone has any questions, comments, please feel free to unmute or chat in, and Elizabeth and I can read it out loud if you'd like. Giving it the long echo pause here. I know Dr. Doyle had to head out around 8:30, but he was telling me how excited he was for this didactic, and
thank you.
Appreciated you as well. Any comments, questions? It's early on a Monday morning, I get it.
It's always good. That,
yeah, exactly. That means you did a wonderful job.
No remaining questions. Good. My point was well taken.
Yeah, exactly. And I'll be attaching your slides in the recap email too, so everyone will get a copy of that. We'll post it on our YouTube, so whoever couldn't join live for the session will be able to watch it there as well.
Okay, sounds good. Thank you very much.
I see you unmuted. Do you have a comment or question?
Hey, Raul. Sorry, I got paged. I had to step out for a second, but I saw sildenafil on one of the slides.
Yes.
Isn't there some work being done on people who develop pH related to their ILD and using some of the pH drugs?
Yeah, so interestingly, there is some thought, I want to answer that in a light with how the antifibrotics impact the different forms of component of interstitium. So there is some thought process, the same TGF-beta and the same the growth factors also leads to the fibrosis around the pulmonary arterioles. So that was the promises where they wanted to see the sildenafil as a pulmonary vasodilator plus the antifibrotic. And I believe the trial name was STEP-IPF, where it was overall negative trial, except when they look at the subgroup of the patients who have developed right heart failure and the pH, there was some positive signals. And I think there is one clinical trial undergoing looking into sildenafil plus antifibrotic. And I'm not sure what's the current status. I haven't read. Probably I will look into that as well. But there is some thought process that it's the same factors that plays along, which leads to fibrosis in the alveolar units, also affects the adjoining arterioles, and leads to emergence of the pH in advanced forms of ILDs. And that's where you see nowadays we talk often about some of the pulmonary vasodilators, the inhaled Tyvaso, being used for group 3 pH. And I believe in future, the thing's gonna evolve even for the pH. They are just probably either gonna refine more different molecules, but I think the thought is already triggered in that direction. And they are already exploring that part. That is the antifibrotic affects some of the pH specific markers or not. There's not much difference, unfortunately, with antifibrotic on 6-minute walk distance or the respiratory symptoms questionnaire they ask to patients. So once they see that early signature, I think they're gonna propel that as it could be an effective therapy for pH as well, like not as an add-on therapy, not a primary therapy.
Okay. And the only other question I had was, and you might have mentioned this, but have they looked at using, 2 different antifibrotics in the same patient?
They did look up. There was some benefit. It was an NEGM trial. I think I probably had it in my list of all the trials. So it had some positive signature on some patient population, but the catch was it was a lot more GI side effect. Almost 70% of them had GI side effect and early interruptions. So that's where it's not getting that much popularity. But very interestingly, the same trial, which I did not put the data on the slide, which showed the mortality benefit, they say that when you switch from the antifibrotic, one antifibrotic to the other antifibrotic, hazard ratio actually decreases even further. So there is I have been used that technique for some of my patients who have intolerability to one antifibrotic or some way they cannot get one. Then and if there is a right indication, I explore them to get the other one. And sometimes if a patient is truly kind of not finding benefit or still noticing some progression, I have used on 1 or 2 instances, I have tried to switch them to different antifibrotic. All right.
Thank you so much for the question and comment, Dr. Stansbury. Any other questions or comments for Dr. Sangani from the group? All right.
All
Well,
right.
if there are any questions after the fact, just shoot me an email and I'll pass it along to you, Dr. Sangani.
Yeah. Thank you, Mitra.
Thank
you,
so
everyone.
much. Only announcement for today is that the September 5th session will be canceled for Labor Day. So the next time we'll meet is on September 19th. And Dr. Sela is presenting on outpatient pulmonary rehab. So keep an eye out for that reminder. I hope you all have a wonderful Labor Day and we look forward to seeing you all next time. Thank you.
Thank you.
Thanks, Dr. Sangani. Take care.